I'm Dan Hilleman. I'm a professor of pharmacy practice at Creighton University in Omaha, Nebraska. The presentation today is the second in the series on acute coronary syndrome, and specifically we're going to talk about non-ST elevation acute coronary syndrome. And clinically, there are two primary, clinical presentations. The first are patients that develop myocardial infarction, which the diagnosis is based on positive cardiac enzymes. And the second, and typically also evidence that there's been significant segmental wall motion abnormality, where the infarct occurred, an echo or heart cath will show that part of the wall of the left ventricle is not functioning properly. So those two variables confirm that the patients had a myocardial infarction. The second is just unstable angina, where they have, the syndrome of chest pain, etc., but their enzymes may be positive but not very high, and typically their echo or angiogram, their LV gram, the left ventriculography, doesn't show significant heart muscle damage. So, as with the prior presentation, there is an accompanying PowerPoint slide presentation, and for those of you who prefer just to listen to the audio, I will be referring to the PowerPoint by slide number as best that I can remember to do that. And so slide 1 for the presentation is just the title slide. And so if we go to slide 2 in the presentation, the pathogenesis of non-ST segment elevation MI or unstable angina is actually, for the most part, the same as STEMI. Patients have significant atherosclerotic plaque. That plaque ruptures. The contents of the plaque, which is a lipid, collagen, smooth muscle cell mixture, is extruded into the lumen of the coronary artery, and that obviously stimulates clot formation. And it's the combination of the contents of the plaque rupture and the clot that blocks blood flow. For patients that have non-STEMI or unstable angina, generally the occlusion of the artery is subtotal, so there's blood flow that gets past the occlusion. Or if it's total, it's intermittent. It will be totally occluded, and then the body's natural process of dissolving clot, etc., removes that clot. And so if there is total occlusion, it isn't for very long. But the underlying initial steps to produce the syndrome of non-ST acute coronary syndrome is basically the same as STEMI. Again, I mentioned during the STEMI lecture why some patients develop STEMI, others develop unstable angina or non-STEMI. We really don't know why that occurs. On slide 2, there are some other causes of non-STEMI unstable angina, and so these are perhaps a bit more important than it was for STEMI. Dynamic obstruction spasm, we talked a little bit about that before. Patients with severely progressive atherosclerosis, 98, 99% blockage, who then go out and vigorously exercise. Inflammatory, we think that there's an inflammatory component to some of the ulceration, rupture of the plaque, but we know that giving antibiotics does not reduce the risk of adverse outcomes in these patients. So, that's still just a theory. There are some secondary potential causes of unstable angina in particular, or non-STEMI, that are not related to coronary atherosclerosis. Hypotension, anemia, hypoxia for whatever reason, a fever, tachycardia, thyrotoxicosis, anything that can substantially alter oxygen supply and demand to the heart could theoretically cause unstable angina. So I think, at least in this case of non-STEMI unstable angina, the potential for causes other than plaque rupture and thrombus are greater. Slide 3, presentation. Again, it's impossible to tell if it's STEMI, non-STEMI, unstable angina simply on the basis of symptoms. You need the EKG, you need cardiac biomarkers, you need a good history and physical. Chest pain that's consistent with myocardial ischemia typically is rest pain that lasts longer than 20 minutes, new onset chest pain, or increasing frequency or severity of chest pain. All of those would be consistent with acute coronary syndrome. But again, just on the basis of the quality or location of the chest pain, it doesn't allow one to reach the diagnosis of STEMI versus non-STEMI or unstable angina. You really need that EKG and you need the cardiac biomarkers. Now, in the patient that presents with non-STEMI acute coronary syndrome, non-ST elevation acute coronary syndrome, we have the patients that go on to develop MI based on enzymes, and then we have those with unstable angina. So we do have, unlike STEMI, where there's a medical emergency, they need to be treated very rapidly. The patient that presents with non-ST acute coronary syndrome, there's a little bit more time to make some decisions about the most appropriate medical and interventional therapy. One of the tools that's used commonly to assess risk in these patients is what's called the TIMI risk score. TIMI, it stands for thrombolysis and myocardial infarction. It was originally the name of a couple of studies looking at lytic therapy, and it progressed to the point that TIMI now represents a group of investigators that do studies together. But the TIMI risk score, as you see on slide 4, is a relatively straightforward approach to where you can look at a number of risk factors, in fact 7 different risk factors. And each of those risk factors is given a weight of 1. So you add up the number of risk factors, and the maximal score that you can have is 7. The minimal score that you can have is 0. So you add up the number of risk factors, and then at the bottom, you'll note that the TIMI risk score correlates with a percentage of risk of either dying, having a myocardial infarction, or requiring urgent revascularization. So the higher the number, the poorer the prognosis. So when you look at the TIMI risk score, this tells you generally the higher the risk, the more urgent the need to take the patient to the cath lab. The lower the risk generally gives you an option of you probably still are going to take that patient to the cath lab, but they don't have to go in an urgent or emergent fashion. They don't have to go in the middle of the night. They may not have to go over a weekend. You have some time, we think, to manage them medically and do the angiography on a more elective basis. One point that I would make here is that when you look at the risk factors, the one that tends to confuse people are the greater than or equal to 3 cardiac risk factors. What those are, the major atherosclerotic risk factors like smoking, hypertension, diabetes, male, gender, etc. Those, you have to have 3 or more of those to get 1 point. So you don't get multiple points for each risk factor. It's simply more than 3 gives you 1 point in the TIMI risk score. The other thing is that the point system is not absolute. We generally think patients that have 0 to 2 points would be low risk, and then those that 3 or 4 would be intermediate risk, and those from 5 to 7 would be at high risk. But again, it's not, this has been developed from several large unstable angina non-STEMI trials, and we think that it's validated and tested very well. But it's not absolute. I mean, there are the difference between 1 point and 2 points, I'm not certain that that gives us a tremendous amount of help in terms of deciding, is this really a patient that can sit for a day, or does that patient need to go in the next 12 hours? I don't know that gives us that kind of sensitivity and specificity in terms of the diagnosis. Slide 5 has a list of types of pain that are not consistent with myocardial ischemia. And so I think it's important to be able to recognize the fact that, for instance, if you have a patient who presents with pleuritic pain, a sharp or knife-like pain brought on by breathing, respiration, or coughing, probably not related to the myocardium. Pain located in the middle or lower abdomen, generally not cardiac. Pain that can be localized on the tip of one finger. Pain reproduced with movement of the chest wall or the arms, or by palpation, pushing. That typically isn't consistent with heart pain. Constant pain lasting many hours, pain lasting a few seconds, pain radiating to lower extremities. All of those would, I think, raise some concern that this perhaps is atypical and may not be cardiac. Slide 6, this is a treatment algorithm, much as we saw for STEMI. And I think it's important because it lists, I think, most of what we really need to know in terms of general management strategy for patients who present with non-ST elevated myocardial infarction or unstable angina. And again, I want to point out that non-ST acute coronary syndrome, we oftentimes don't have enzymes back. We can't call a diagnosis of MI in the first hour of presentation. And these people typically need to be triaged and treated. They get the EKG. There's no ST segment elevation. You're doing serial EKGs, serial enzymes, oxygen, and they're going to be admitted to be worked up. So this pathway, if you will, I think is still a very valid management strategy approach. And so I think we need to take a look at this. This is slide 6. Initially, these are the drugs that are going to be administered to these patients. And again, they're managed similarly. Aspirin for all patients. Beta blockers unless contraindicated. Nitrates, particularly if they have chest pain. An antithrombotic regimen, which is going to be some type of heparin or maybe fondaparinux. A glycoprotein 2B3 receptor antagonist, perhaps. And then obviously they need to be monitored. You put them on a telemetry floor, typically, for continuous electrocardiographic monitoring. Now, you could, I guess, throw in here statin, although the statin trials for acute coronary syndrome, the window of intervention was up to 72 hours. So I don't know that statins have to be given in the first 12 hours or first 24, but they often are given that early. But they don't have to be necessarily. Just a word about the drugs, and we're going to talk about these in greater length in a minute, but aspirin and heparin, some type of heparin, have been shown to reduce mortality in this syndrome. And the glycoprotein 2B3 receptor antagonists have also been shown to reduce mortality. Beta blockers and nitrates have not. They specifically are anti-ischemic, but we don't have good randomized controlled trial data to tell us that using IV nitro or giving beta blocker reduces mortality in the non-ST acute coronary syndrome patient. So those are the treatments that typically are started, initiated. The question then is, should the patient go for urgent or perhaps even immediate angiography? And it depends on their TIMI risk score. I think if their TIMI risk score is 5 or higher, I would want to see that patient in the cath lab sooner rather than later. If it's a 3 or 4, then I think you've got a little more time. If it's less than 3, then maybe even more time. And in fact, The suggestion in this algorithm is that for the very low-risk patient, you can use an early conservative strategy. You treat the patient medically, and then you wait and see, do they have recurrent symptoms? You look at their left ventricular function, do an echo. You may end up doing a stress test. A stress test with dobutamine or maybe adenosine cardiolite, or maybe just a plain old treadmill, depending on how concerned you are that stress will provoke ischemia and cause problems. But the stress test may turn out to be negative, and the patient may not need angiography at all. However, if the patient has a poor ejection fraction that's new and onset, it's not something you previously knew about, or they have a positive stress test, then they're probably going to need angiography. But the point is, a conservative management approach may end up saving dollars. You end up avoiding doing angiography in patients that don't need it. That's kind of the intent of this particular treatment algorithm. So let's talk about details of the therapy then. And these are guidelines that I think were published in 07 or 06. They have not been updated. Unlike the STEMI guidelines that have been updated in 09, these are still somewhat older. And so there are some things that I'm going to suggest we do differently than what the guidelines suggest, but you could reach your own conclusion about that. So what the guidelines have done is to kind of divide the treatments into those that are used to treat ischemia, those that are used as antiplatelets, those that are used as antithrombotic, etc. So on slide 7, they have anti-ischemic intervention, drugs or interventions that reduce ischemia. So bed rest with ECG monitoring generally is recommended until you decide that you're going to go to the cath lab or whatever, or they're going to go for a stress test. But generally, you don't want these people doing vigorous stuff if they've got, these obviously are people that have had rest pain. Nitroglycerin should only be used for relief of chest pain or ischemia. So you don't have to use nitrates unless the patient has evidence of chest pain. Oxygen for low O2 sats. Again, here it doesn't say give oxygen to everybody. Only if their O2 sats less than 90 on room air. Morphine, again, it's the drug of choice as a narcotic analgesic, but only if patients have pain not relieved by a nitrate or maybe a beta blocker in addition to a nitrate, or if they've got acute pulmonary congestion, they've got pulmonary edema, or they've got agitation and you're trying, your morphine serves multiple purposes there. A beta blocker, here's the part where I guess I'm a little bit, this needs to be updated. They suggest the first dose be given IV. And again, I think the point here is we'd prefer to go oral initially. There is some evidence potentially that, particularly if the patient is borderline hypotensive, systolics less than 100, the IV beta blocker may promote cardiogenic shock. So I don't know that starting people on IV beta blockers is all that crucial. Probably just as well to start with an oral beta blocker in this setting, non-ST acute coronary syndrome. If the beta blocker is contraindicated, and there's really only one, maybe two absolute contraindications that you can't deal with, one is asthma, patients that have bronchospastic disease or COPD, patients who are bradycardic or hypotensive, obviously, either have to have a pacemaker or do something to bring their pressure up. But if you can't use a beta blocker and you want to treat ischemia, you can use a non-dihydropyridine calcium channel blocker, as long as, and the caveat is, they don't have heart failure. If they've got good LV function, you could use a diltiazem to treat ischemia. If the patient's on a beta blocker but continues to have ischemia despite being on the beta blocker, technically you could add a dihydropyridine, a drug like amlodipine or felodipine, to the beta blocker. That would mean less of an inhibitory effect on contractility, less effect on AV node conduction. But getting to that point, maybe if they're having chest pain despite being on nitrates, beta blockers, maybe angiography would be a better step than diltiazem. ACE inhibitors can be used short term. You would not give them IV. Do not use IV in Antiplatelet unless the gut simply doesn't work. But the indication here would be hypertension despite beta blocker nitrate, or if the patient has a low ejection fraction, LV dysfunction, heart failure, or they have diabetes. Then an ACE inhibitor, given orally relatively early during the course of therapy. I don't know that it's necessarily anti-ischemic, but certainly it's indicated for those patients. They do make a recommendation, and this is we're on slide. We're on slide 8. That patients that have ongoing ischemia despite beta blocker and nitrate, you can add the long-acting dihydropyridine. I mentioned this before. It's a 2A level of C recommendation. Again, I guess the question I have is, before you get to that point, if they're having that much pain, ST segment, deviation, a depression, or T-wave inversion, maybe it's time to go to the cath lab. ACE inhibitor for all post-ACS patients, the indication based on, a number of studies suggests that any patient with coronary disease will benefit from ACE inhibitor therapy. But again, the patients that are going to get the most benefit are diabetics, or those with heart failure, those that are hypertensive. Intra-aortic balloon pump and some of the extracorporeal left ventricular assist devices can be used for people that have infarction that are hemodynamically unstable. And it's actually more likely that this would come up in the patient with STEMI, but it's mentioned here in these guidelines. And again, these would be devices that would be used short term to provide hemodynamic stability before the patient would go to the cath lab, or after going to the cath lab. These are folks that are basically in shock. Using an extended release non-dihydropyridine calcium channel blocker instead of a beta blocker is not recommended. It's a 2B recommendation. Adding a short-acting immediate release dihydropyridine to a beta blocker, not recommended. It's 2B. Use a long-acting drug like felodipine, which is extended release, or use amlodipine, which has a naturally long half-life. Again, nitrates, you can't use nitrates if the patient is on an ED drug. You can't use nitrates if they're hypotensive. You can't use nitrates if it's a right ventricular infarct. And again, immediate release dihydropyridine calcium channel blockers, the old nifedipine capsules, contraindicated. I mean, this is old news, but it's still in the guideline. So slide 9, nitrates, again, they don't reduce mortality. They're indicated to reduce ischemia. They're indicated to treat chest pain, sublingual for acute onset, and then give IV to prevent recurrences. The nice thing is that nitrates do dilate collaterals. They dilate diseased coronary arteries. They dilate normal coronary arteries. They don't cause coronary steal. So they generally do good things for the heart in terms of ischemia. Start at 10 mics a minute. We sometimes start even lower at 5. The patients you want to be cautious in are those that are volume depleted, or those that are, their systolic's not all that great. Particularly if you've given them a loop diuretic for edema or whatever. Be careful if they're volume depleted. You can see a precipitous drop in blood pressure. Titrate at 5 to 10 mic per minute increments. This is not a weight-based drug. Every 3 to 5 minutes, and the goal of therapy is relief of ischemia. It's not blood pressure. It's chest pain free, keeping the systolic above 110. Doses up to 200 mics per minute have been given, but rarely are needed. And there is some evidence that you can give prolonged infusions and relatively safe long term, but you're never going to give IV nitro probably for more than 24 hours or so unless there's some really special circumstance. And again, I can't reinforce enough, the nitrate is not being given to reduce adverse cardiovascular outcomes. It's given just to relieve chest pain. If you feel the patient needs a long-acting nitrate, they didn't go to PCI, they have significant coronary atherosclerosis that didn't get fixed, if you will, and you want to use a long-acting nitrate, there's a variety of available agents. Some, I think, are probably easier to use than others. We personally prefer the long-acting isosorbide mononitrate, but I'm sure there are physicians that suggest that they like the transdermal. The key is that tolerance develops. Even with early IV nitrate therapy, you're going to see some tolerance, and the way you manage that with IV is simply to bump the IV infusion dose upward. If it's oral, then you have to allow for an 8 to 12-hour nitrate-free interval each day. So if the patient's wearing a transdermal nitrate patch, they have to take that off at bedtime, put a new one on in the morning. It's a little bit complicated, I guess, for some patients. That's the beauty of the isosorbide mononitrate extended release product. It is designed to run out of nitrate at the end of 12 hours, and so it automatically has a built-in nitrate-free interval. So again, just to emphasize on slide 10 here, no controlled data showing that nitrates reduce events in the setting of non-STACS or even in the setting of STEMI. So they're only used for symptomatic control of angina, prevention of angina long-term. And most patients that have CABG or that get PCI, the percentage of those that go on to develop angina is very low. This slide shows the variety of different types of nitrate formulations. Again, there's no evidence that one is better than another. So you choose the one that you think fits your patient the best, the one that works best for your patient. And again, this is not a plug. It's a generic drug at this point in time. But we like the once-a-day isosorbide mononitrate. We think it's probably the simplest approach for our patients that do need nitrate therapy. Slide 12, beta blockers, generally administered. Again, there are patients either contraindicated or very low risk that have good ejection fractions. But I think for the most part, beta blockers are routinely given to people with non-STACS, even though there's no evidence that they reduce mortality. There's a dozen or more of oral beta blockers around still today. Almost all of them are generic. There's a couple that are branded, I think, still, but most are generic. I think when you have that variety of different agents, most physicians are going to identify one or two drugs they like that meet their needs, that meet their patients' needs. They feel comfortable with the dosing. They know what to expect from those drugs. So we generally think that beta-1 selective drugs are better tolerated, but I can tell you I don't know that there's a great deal of evidence to support that recommendation. I think it's a perception more than a fact, but I think the reality is we generally use beta-1 selective drugs. We also generally don't use the ones with intrinsic sympathomimetic activity. There's only two, acebutolol and pindolol, and they're really only indicated for hypertension anyway, so we tend not to use those. Contraindications, most of these are relative. High-grade conduction disturbance, you're not going to send a patient home with a high-grade AV block anyway. They'll have a pacemaker inserted. Hypotension, you're not going to send people home who are hypotensive. Bradycardic, that's symptomatic. Decompensated heart failure, you need beta blockers, but you've got to start low and titrate slowly in those patients. You can make a patient with heart failure worse if you give beta blocker too aggressively. And then obviously asthma or COPD. Now, slide 13 and slide 14, I have given you a table that gives you pharmacology and pharmacokinetics of all of the beta blockers. I'm not going to read through these. This is for your own edification. You can print these out and use them to whatever advantage you'd like to use them to. A couple of things I guess I would point out. There are several beta blockers that you can give parenterally, IV. Atenolol and metoprolol, there are protocols to give them IV and STEMI. We don't typically do that anymore because of the concern of cardiogenic shock. We prefer to start oral. Propranolol can be given IV. But the beta blocker that really has the best data for continuous infusion is esmolol. Now, the thing about esmolol, it's ultra short acting. The nice thing is if you develop a problem that you think is beta blocker related, you can shut it off. The effects wear off relatively gradually. But I would point out esmolol is expensive. Probably want to use it for as short as period of time as possible, 12 hours, 24, probably never beyond 24 hours unless it's absolutely necessary. So keep in mind that there are drugs that are both alpha and beta blockers. We use carvedilol a lot. It's a non-selective beta blocker, but it's also an alpha blocker, and there's very good data with carvedilol for heart failure and for MI. So the beta blockers we tend to use in our practice is metoprolol, which is a beta-1 selective drug, and then, of course, carvedilol, which we tend to use particularly for those patients with LV dysfunction. Both of the immediate release forms of those drugs are generic at this point, and so they're relatively inexpensive. Route of elimination on slide 15 with the beta blockers. We know that there are some beta blockers that are predominantly water-soluble, long intrinsic half-life, cleared by the kidney. Atenolol, sotalol, these are the drugs on the right-hand side of this graph. The interesting and important point is that sotalol, for instance, you have to have a creatinine clearance available to make dose adjustments. It's actually a beta blocker that's used as a class 3 antiarrhythmic drug. But the drugs on the left-hand side of the graph are more lipophilic. They have shorter intrinsic half-lives and are metabolized by the liver. So they tend to have to be given more than once a day, twice, 3 times a day. Some are an extended release. The question that I think that we don't have an absolute answer to is, are the water-soluble drugs less likely to penetrate the central nervous system and cause fewer CNS side effects? And I don't know the answer to that. I mean, there's some evidence both ways. And so if you have a patient who has problems with CNS side effects with a beta blocker, sleep disturbance, worsened depression, maybe a water-soluble drug like atenolol, which is beta-1 selective, maybe that would be a better choice. I don't know, but anecdotally, it may be an option. Side effects of beta blockers on slide 16. Most of these are predictable based on the pharmacology. Sleep disturbance, worsening depression, those are the central nervous system effects. Diabetes is not a relative contraindication. There's no reason to withhold beta blockers in diabetics. If they're insulin-dependent diabetics, type 1, the beta blocker may mask some of the hypoglycemia if the patient takes too much insulin. The other problem is if the patient who has type 1 diabetes becomes hypoglycemic, the gluconeogenesis through the liver is under autonomic control, under sympathetic control, and beta blockers may slow return to euglycemia. So it's a little bit of a problem, and I'm not suggesting that we don't be cautious in type 1 diabetics, but it's not a contraindication. We know that diabetics, in fact, in the mortality trials, derive more benefit from beta blockers than patients without diabetes. Type 2 diabetics, interestingly enough, they still produce insulin. Pancreas is still pumping out a little insulin. And the insulin secretion is under sympathetic control. So when you start a beta blocker in a type 2 diabetic, some patients there's a reduction or a blunting of insulin release. That means blood sugar is actually going to go up. So you may have a patient who does finger sticks routinely with type 2 diabetes, who you start on a beta blocker and they'll report, my blood sugars are a little out of control. They're a little bit higher. It may be the beta blocker. I'm not aware of beta blockers inducing new onset diabetes, nor resulting in the need to really ramp up diabetic therapy. But I think you need to be aware that there's that potential for an increase in blood sugar when you add a beta blocker to a patient with type 2 diabetes. Beta blockers do reduce exercise capacity. When patients get on a treadmill, for instance, their heart rates are blunted with increases in exercise. So they can't walk as long as they normally would. So a younger patient who is active, you know, some patients after infarct do end up going back and being fairly active. They can jog, they can play tennis. They may report some exercise intolerance. Bronchospasm, I think that the one absolute contraindication is that patient with asthma who has a lot of episodes of bronchospasm. Beta blockers are bad news in those people. COPD is a tougher call. I tend to look at, if we have PFTs, what's the FEV1? The FEV1's below 35%, I say forget it. If they've been in the hospital with exacerbations, I say forget it. But, you know, there are some patients where beta blockers may outweigh the risk of you know, the effect on the lung. So it's an individual decision, and so that's something to think about. Beta blockers do cause erectile dysfunction in men. One of the beta blockers that's new, that's on the list in that table that I gave you, is a drug called nebivolol, which the trade name is Bistolic or Bistolic. It's only indicated for hypertension, but it increases nitric oxide. And we think, well, we know, one, it doesn't cause erectile dysfunction. It's been studied in several trials showing no increase in erectile dysfunction. So we actually have had some evidence that men who were switched from metoprolol in particular to nebivolol reduced the amount of erectile dysfunction medicine, that you know, Viagra, that they needed to use on a regular basis. So that may be an advantage for nebivolol. It's not approved for anything else other than hypertension. I think that makes a number of us suspicious. You know, it was studied for heart failure, but the FDA turned it down. So I don't think we would routinely use it post-MI, but if the patient won't take another beta blocker because of impotence, nebivolol is probably better than nothing. Heart failure, we already talked about this. You know, if you have someone with decompensated heart failure, adding beta blocker at full dose can make them worse. Denervation hypersensitivity is a phenomenon that occurs when you have a patient who's been on high-dose beta blocker and then you suddenly discontinue the beta blocker. You abruptly stop it. The patient's exposed to a stressful situation where sympathetic tone goes up. These patients can develop hypertension, ischemia, heart attack. It typically occurs following surgery. Patient's been on high-dose beta blocker for angina, has CABG surgery, they forget to restart the beta blocker, and then the patient develops severe hypertension post-op. All they need is a little beta blocker to deal with that. Calcium channel blockers, again, the use of calcium channel blockers for myocardial ischemia, I think has gone way south. We just don't use it much, those drugs much anymore for ischemia. There's still, you know, amlodipine still gets a fair amount of use for hypertension. I think it's a good drug in that setting. We use a lot of the non-dihydropyridines, particularly diltiazem, to control heart rate for AFib. But in the setting of STEMI and non-STEMI and stable angina, only probably for patients that either can't take a beta blocker or who continue to have ischemia despite beta blocker and a nitrate. The two main types of calcium channel blockers are the dihydropyridines, which are vasoselective. They're primarily drugs that lower vascular resistance, but have little effect on contractility, little effect on SA-AV node. So amlodipine is a drug that you can use for angina, hypertension, vasospastic angina, but you can't use it to control rate in AFib. But the other advantage of the dihydropyridine is that they do not worsen heart failure. So diltiazem, verapamil, they also are vasodilators. They work for hypertension. They work for angina. They'll work for vasospasm. But they do tend to lower cardiac output. They inhibit contractility. So they're relatively contraindicated in heart failure. And they have an inhibitory effect on the SA-AV node. So you can use them as antiarrhythmic drugs to slow ventricular rate in AFib, or you can use them to terminate PSVT. Now, they're not in the algorithm anymore for PSVT, but they do work for that indication. So slide, I believe we're on slide 18 here. Really, the role of calcium channel blockers is limited, only for that patient that can't take a beta blocker or where there's persistent ischemia despite beta blocker or nitrate. We really have a concern that these drugs cause arterial vasodilation, which induces reflex tachycardia and can increase catecholamine levels and ischemia. So we want to be very careful, particularly with short-acting calcium blockers. They should not be used at all. The non-dihydropyridine calcium channel blocker, obviously we have concerns if you have a low ejection fraction or heart failure. If you're on a beta blocker, the patient's on a beta blocker, and they have a need to have a calcium channel blocker added, use a dihydropyridine. There's less effect on contractility. There's less effect on conduction. If the patient's not on a beta blocker and you feel the need to use a calcium antagonist, then a non-dihydropyridine drug probably is the best choice, particularly in a patient with myocardial ischemia. They tend to blunt their own ability to cause reflex tachycardia because of the inhibitory effect on the SA or AV node. Slide 19, this slide gives you kinetics, dosing, other information about the dihydropyridine calcium channel blockers. I'm not going to read through it. It's there again for your use. There are obviously a whole bunch of dihydropyridines. All of the generic names of the dihydropyridines end in INE. That's one way to keep them straight. The other is simply the only two non-dihydropyridines are diltiazem and verapamil, which are shown on slide 20. So again, I'm not going to read through this. You can read this as well as I can, but it gives you, I think, a nice resource in terms of if you get questions about the different calcium channel blockers that are available. Side effects of calcium channel blockers on slide 21. Obviously, we've kind of covered most of these, but diltiazem, verapamil will worsen heart failure. Amlodipine, felodipine, we know will not. They specifically have been studied in patients with heart failure and no worsening. So the point, I think, is if you have a need to use a calcium blocker in a patient with heart failure, to treat hypertension, to treat angina, the dihydropyridine is the drug that's going to be the safest from the standpoint of heart failure. AV block, second-degree heart block, rarely, I guess, complete heart block. Only a problem with verapamil or diltiazem. The other effects of inhibiting calcium influx into smooth muscle, for instance, in the gut, in arteries that cause dizziness, flushing, headache, peripheral edema, gingival hyperplasia, reflex tachycardia, all of those vasodilatory kinds of side effects tend to occur more commonly with dihydropyridines. Now, the one exception is the effect on the gut. Constipation, a movement of calcium in smooth muscle in the gut, appears to be much worse with verapamil than with diltiazem or dihydropyridines. One of the biggest complaints we get with chronic verapamil use, particularly in the elderly, is constipation. And so we tend to avoid verapamil. We don't use verapamil much at all for anything, simply because diltiazem is available and does, I think, at least as good a job as verapamil for most indications. Again, the reflex tachycardia is a problem in acute myocardial ischemia. Short-acting hydropyridines, you're probably sick of hearing me say this, do not use them in patients with myocardial ischemia. There's data showing that nifedipine capsules increase mortality in patients with acute MI, and so clearly contraindicated. Antiplatelet and anticoagulant therapy in non-ST acute coronary syndrome. All of these patients should get aspirin and continue it indefinitely. Plavix or clopidogrel is a reasonable alternative to aspirin. Prasugrel, which is the new thienopyridine, there's no data outside of acute coronary syndrome in patients that get PCI. So it does not have the indication as an alternative to aspirin, but I guess if you had a patient who was Plavix allergic and you needed dual antiplatelet therapy, certainly Prasugrel could be used, or it could be used as an alternative to aspirin, even though it's outside of labeling. There is evidence in post-MI, the non-STEMI, the non-ST ACS, that dual antiplatelet therapy, even without stenting, reduces events, and that data, there's data suggesting that combined therapy for up to 9 months, which comes from the CURE trial, shows that aspirin and Plavix together reduces events. So you don't necessarily have to have had PCI for dual antiplatelet therapy to reduce events. You've heard this before, but both Prasugrel and clopidogrel, if the patient's going to CABG, you want to withhold that therapy for a minimum of 5 to 7 days. We know that antithrombotic therapy, both low molecular weight heparin and unfractionated heparin, combined with aspirin and or clopidogrel, reduces mortality in these people with non-ST acute coronary syndrome. The use of glycoprotein 2B3A receptor antagonist is best reserved for patients that are going for PCI. And when you give it in conjunction with aspirin and clopidogrel or Prasugrel, the IV antiplatelet drugs reduce stent thrombosis. They reduce thrombosis at the site of angioplasty. Now, years ago, when PCI was not a routine part of management of these patients, giving prolonged infusions of the short-acting, the small molecule glycoprotein 2B3 receptor antagonist, which are eptifibatide, which is integralin, or tirofiban, which is aggrastat. You could give those as an infusion with heparin and aspirin for up to 96 hours. And that data suggests, it was compared to placebo, that those drugs reduce mortality. Now, the rates of events were small. 2.5% with placebo, 1.8% with the glycoprotein drugs, but it was statistically significant. The current recommendation is, if the patient's not going to go to PCI and they have ischemia and elevated troponin levels or other high-risk characteristics, then you can administer these drugs IV to reduce those events. But the reality is, the vast majority of patients go for angiography at some point. Most people don't use these glycoprotein drugs, what we call upstream, prior to PCI. Slide slide 23. There is probably stronger evidence with low molecular weight heparin, particularly enoxaparin, compared to unfractionated heparin for acute coronary syndrome, for non-ST acute coronary syndrome. The problem that we see is that there's data showing that if the patient's treated with one type of heparin and then gets switched to another type of heparin in the cath lab, there is an increased risk of bleeding. And the study that looked at this was the Synergy trial. But patients were treated with low molecular weight heparin prior to going to the cath lab. At the cath lab, they switched them to unfractionated heparin, and their bleeding rates were increased, and vice versa. Those that got unfractionated heparin were then switched to low molecular weight heparin, a higher rate of bleeding. My suggestion, and I think what we do at our institution, since most of our patients go for angiography relatively early in the course of hospitalization, they're only going to be waiting a few hours. We put most of our patients on unfractionated heparin because that's what they get during PCI, during the angiography. They'll give them unfractionated heparin and monitor the ACT. If you use low molecular weight heparin, the ACT is not affected as much. So I think there's, my sense is that if PCI or CABG is planned, unfractionated heparin is probably a simpler antithrombotic regimen to use. Now, one other question is glycoprotein 2B3 receptor antagonists. We've kind of had this discussion. There are some institutions that like to use heparin plus an IV antiplatelet drug during PCI. Some other hospitals are using bivalrudin instead, and rates of bleeding apparently are lower. So that data applies not only to STEMI, but also to non-ST acute coronary syndrome. On this particular slide, it talks again about the small molecule IV antiplatelet drugs, eptifibatide, trofaban, that you can give them IV, but unless they have high-risk features or ongoing ischemia, it's a 2B recommendation. So, you know, they've got to have a strong reason to give those drugs IV. And abciximab, interestingly enough, was tested as a treatment for unstable angina in patients not going for PCI. It didn't work, and we don't know why. But maybe the infusion was simply, you know, the dose was, I don't know, the dose may have been inadequate, but you should not use ReaPro or abciximab for unstable angina if you're treating it in advance of you know, a delay before they go to PCI. Slide 24, obviously this is a slide that covers the use of aspirin. Patients previously taking aspirin, then you can continue whatever dose they were on. If they're not on aspirin, then the recommendation is to start with the high dose, the 325, get sufficient antiplatelet effect going quickly as possible, chew 4-baby aspirin. If the patient does not have stents placed, then you can use the low-dose maintenance. If the patient has a stent, then the recommendation is to use 325. If it's bare metal, then it could be theoretically kept at 325 for 4 weeks and then drop back. But we really feel that 325 for 12 months is preferred, especially if they have a drug-eluting stent. Contraindications to aspirin, you know, if they don't tolerate it, obviously. You can try buffered, you can try enteric-coated. There's no hard evidence that those reduce tolerance, especially adding bufferin, you know, buffered antacid. Enteric-coated may work a little bit better, people that have a lot of upset stomach with aspirin. And you can try low dose in those patients. Sometimes it makes a difference. 81's better tolerated than 325. Maybe a little less GI bleeding with 75 or 80 compared to 325 as well. Patients who have allergy, patients who are actively bleeding or have hemophilia, patients with severe elevated systolic pressure that's not treated, active peptic ulcer, or those with thrombocytopenia. Ticlopidine was the first phenopyridine-derived derivative that was marketed. A lot of GI upset. It was a prodrug. It took a long time to work. Up to 40% of patients had significant GI intolerance. The thing that really kind of killed ticlopidine was the finding that it caused neutropenia. Overall, 2.5% developed it, and it was severe in about 0.8%. So the labeling got changed, that CBC, a complete blood count, had to be drawn every 2 weeks for 3 months. Thrombocytic thrombotic purpura can occur with any thienopyridine. It's potentially life-threatening, and plasma exchange is recommended to reduce mortality. Fortunately, it's very rare, but could happen with any thienopyridine. Clopidogrel, Plavix, been around for quite a while now. Obviously, like ticlopidine, it's an irreversible platelet inhibitor. It has a better GI tolerance profile than ticlopidine. A much smaller number of people complain of dyspepsia. No bone marrow suppression, at least no more than aspirin. It is a prodrug, and so it's a complicated conversion, delayed onset of effect, and that's, I think, one of the big limiting steps of using it. It goes through 2 CYP isozyme conversions to become active. So there's a loading dose that needs to be given, and even with the loading dose, it takes up to 4 hours to see a peak antiplatelet effect. They've tested 300, 600, and 900. 900 is no better than 6. So it kind of depends. If you've got some time before angiography, 300 is probably sufficient. But if you're going to the cath lab urgently, 600 is recommended. Food doesn't affect absorption. 75 milligrams a day is the maintenance dose. There is a little bit of data that for high-risk patients or those that have clopidogrel resistance, that 150 milligrams a day may be better. Obviously, that's not a cheap treatment regimen. We're talking $8 a day for 150 milligrams per day of clopidogrel. There's also a couple of other issues with clopidogrel. Drugs that inhibit cytochrome P450-3A4 or 2C19 can block the conversion to its active metabolite. Now, whether that's clinically important, we don't know. But statins and proton pump inhibitors, at least in vitro, block conversion of Plavix to the active metabolite and reduce its ability to inhibit platelet aggregation. So the FDA, surprisingly enough, put a warning on clopidogrel in its package insert that it could not be administered with omeprazole, which is a relatively potent 2C9 inhibitor. There apparently are some other proton pump inhibitors like pantoprazole that have less effect. But there isn't a lot of clinical evidence that this interaction leads to an increase in adverse outcomes. So it appears that it's mostly a test tube phenomenon. Prasugrel is a new thienopyridine drug just approved in 2009. It is limited in terms of indication to only patients with acute coronary syndrome who are going to be managed with PCI. 60 milligram is the loading dose, 10 milligrams is the maintenance, except for patients who weigh less than 60 kilos or about 130 pounds. Lightweight patients you can get by with 5 milligrams a day. Take it with food or not, doesn't affect absorption. It is a prodrug, but the conversion of Prasugrel is one step. It's converted in the intestinal wall by human carboxyl esterase, and then one CYP P450 step. And the interesting thing is any number of 5 or 6 different CYP isozymes will convert that thiolactone intermediate produced by the esterase in the intestinal wall to the active Prasugrel metabolite. So we know that Prasugrel is not affected by drug interactions. We know that there is no effect of polymorphism in the cytochrome P450 isozymes. Both of those things tend to have an adverse effect on clopidogrel conversion. There are hypo producers of cytochrome P452C19 who don't respond to Plavix, and then the drug interactions with Plavix. Neither of those are problems with Prasugrel. We think, based on the evidence, Prasugrel is a better antiplatelet drug. And the clinical trial data tells us that. The only downside is that Prasugrel also is associated with a higher risk of significant bleeding. This slide, which is slide 28, shows you the metabolic pathway for clopidogrel and for prasugrel. And you'll notice that clopidogrel goes through two cytochrome P450 isozyme conversions. The first is cytochrome P453A4. The second is 2C19. Either one of those can be blocked, and you end up inhibiting production of active metabolite. Whereas with prasugrel, the intestinal esterase converts it to this thiolactone intermediate, and one cytochrome P450 step, which again could be 3A4, 2C19, 2B6, a number of different isozymes can convert it to its active metabolite. So if you give a potent inhibitor of 3A4 like ketoconazole, it still produces active metabolite. You give omeprazole, it still produces active metabolite. So there are some significant advantages of prasugrel, and one of those is that the onset of effect, if you look at this slide, the table looking at the different antiplatelet drugs that are available orally, clopidogrel, even at 600 milligrams, you only get about a 40% inhibition of platelet aggregation. It takes 4 hours to see the peak effect. The effect is not very consistent because of differences in enzyme levels, because of drug interactions. Prasugrel, much more consistent, 80% inhibition of antiplatelet effect, of platelet aggregation, and the peak effect occurs at 1 hour. So it works as well as the IV antiplatelet drugs, only it's given orally. The problem with prasugrel is an increased risk of bleeding. Contraindications are active pathological bleeding, prior TIA or stroke. If you've ever had a stroke or TIA at any time in the past, those patients cannot receive prasugrel. They're contraindicated because in the trial they had a significant increased risk of stroke if they had the prior history. Warnings and precautions, all of these are related to increased risk of bleeding. Age greater than 75 years. If they have to have CABG, you have to stop prasugrel for 7 days. If they weigh less than 60 kilos, they can only take 5 milligrams. If they have a propensity to bleed, liver disease, etc., they have an increased risk of bleeding. And then long-term drugs like warfarin, non-steroidals also are going to increase the risk of bleeding with prasugrel. And in the label, it does say thrombotic thrombocytopenic purpura. Again, this could happen with any thanopyridine. I'm not aware of any cases that have been reported with prasugrel. Slide 31 basically shows the results of what the main study that compared prasugrel to clopidogrel was called Creighton TIMI 38. The excess risk of any bleeding was 1% higher with prasugrel than clopidogrel. The excess risk of life-threatening bleeding was 0.5% higher. So 5 out of every 10,000 patients treated, more than clopidogrel, will have a life-threatening bleed on prasugrel. Look at the patients who weigh less than 60 kilos and those that went for emergency CABG where these drugs couldn't be stopped. 14% with prasugrel. It's 3 times more than clopidogrel. I think the issue here is, and the concern is, the bleeding with prasugrel tended to occur over the course of the 12 months of follow-up. This was not just bleeding at the time they were doing the PCI. This was bleeding that occurred at 6 months, 9 months down the road, and patients would have bleeding in their gut and not know it. And they wouldn't present to the emergency room until they had significant blood loss. And of course, then they end up with what was quote-unquote life-threatening bleeding. Now, fatal bleeding, the difference is very low for both drugs, but about 0.2% more with prasugrel. So this is what's, I think, concerned physicians. I don't know that prasugrel has been universally accepted. There are some institutions that use it routinely. If you look at the efficacy data, clearly it's better than clopidogrel. 13,000 patients randomized, about 3,500 had STEMI, the other 10,000 had non-STEMI, unstable angina. The composite endpoint was death, cardiovascular death, non-fatal heart attack, non-fatal stroke. Prasugrel reduced that risk by about 2%. 2 patients per 100 had fewer heart attacks. That was the driving variable that ended up leading to the significant reduction in events. But the offset then is this 0.5% increase of life-threatening bleeding. And so I think the net benefit, if you really looked at it mathematically, is about 1.5%, or 1.5 patients per 100 had better outcomes with Prasugrel. So I think, you know, when you look at why the FDA approved this drug, and it was controversial. A lot of physicians didn't think this drug should come to market. What the FDA said was, well, you prevent 2 heart attacks where there's significant loss of heart muscle that you can never replace. And the offset is you have this increased risk of bleeding, 1% overall, 0.5% for life-threatening. So if you survive the bleeding episode, and the difference in mortality for fatal bleeds was very, very, very small, if you survive the bleeding episode, you haven't lost anything. Whereas if you have a heart attack, down the road you may develop heart failure, you may develop arrhythmias. And so that was the trade-off. And I'm not pushing Prasugrel, I'm telling you the facts. The trade-off is fewer heart attacks for that slight increased risk of a serious bleed. The National Institute for Clinical Excellence, which is out of the United Kingdom, which does very, very good work in terms of evaluating new drugs, what they concluded was there are 3 indications for Prasugrel. One is for STEMI patients, where you need that rapid antiplatelet effect that occurs at 1 hour, 80% inhibition, clearly better than clopidogrel there. It's also better in diabetics who have very sticky platelets, tend to have more thrombotic events. Clearly diabetics did better with Prasugrel. And lastly, patients that develop stent thrombosis while they're on clopidogrel. So those are the 3 areas where Prasugrel really is preferred compared to clopidogrel. Glycoprotein 2B3 receptor antagonist, we've already kind of talked about these drugs at different times. They're still used, I think, routinely in people going for PCI in the setting of non-ST acute coronary syndrome. The data here is a little different than it is in STEMI. I don't know that it's absolutely necessary to give these drugs, but a lot of institutions still do. We use integralin or eptifibatide as our workhorse. It's cheaper than abciximab. Tirofiban has very little data in PCI, and it's not improved in that setting. Again, the argument is there are some institutions that use heparin plus a glycoprotein 2B3 receptor antagonist. We know that it reduces thrombotic events after PCI. The alternative is bivalirudin, which works probably as well but with slightly fewer bleeds. The only difference is that with bivalirudin, there is going to be a little higher rate of stent thrombosis. Some of that stent thrombosis can be fairly severe. Some is subtotal and not as severe. So I guess it just kind of depends on, you know, what your institutional practice is as to what type of practice they're going to follow. We have patients that we use bivalirudin in because they're at higher risk for bleeding. A couple of things to keep in mind when we look at the different glycoprotein 2B3 receptor antagonists in slide 30, I believe this is slide 34. The doses that are used for PCI are a little different than the doses that were approved for prolonged infusion. Now, abciximab has been the same dose forever, 0.25 milligram per kilogram bolus, and then 0.125 mics per kilo per minute for 12 hours. Eptifibatide, when it's used for PCI, is a double bolus, and then 2 mics per kilo per minute. Unless the patient has renal dysfunction, the renal dose, people with creatinine clearance, is less than 30, less than 45, somewhere in there, cut back to 1 mic per kilo per minute. Again, tirofiban, There are some studies published using the higher bolus, 25 mics per kilo, but it's not FDA approved. So I don't know. We tend not to use tirofiban for any indication. One other thing to keep in mind is that abciximab is not cleared by renal or hepatic. It's cleared by reticular endothelial uptake, so you don't have to make dose adjustments for renal or hepatic function, whereas both eptifibatide, tirofiban, they are reversible platelet inhibitors. You shut the infusion off, the platelets recover. Plus, they're cleared renally. So you got to make dose adjustments in patients with renal dysfunction. This table shows you some of the pharmacologic characteristics of the different glycoprotein 2B3 receptor antagonists that are on the market. There's only 3. And I'm not going to read through this, but again, it's a nice little table that gives you some of the recommended doses, some of the pharmacologic properties of these drugs, particularly in the setting of PCI. On this slide, what we're looking at here is unfractionated heparin dosing. Many patients will be put on heparin while they're waiting to go to the cath lab. Remember, aspirin and heparin are 2 of the drugs that reduce mortality in the non-ST-ACS patient. So you'll notice here that there's dosing based for non-STEMI and then STEMI. So if the patient, in the old days, if they were getting a glycoprotein 2B3A receptor antagonist as part of the treatment strategy, which isn't done much anymore, the dose that was recommended was a little different than the dose that we give without those drugs. So at the bottom left-hand side of the slide, 70 units per kilo, 15 units per kilo per hour can be used. Keep in mind that typically the recommended max is 5,000, 1,000, but you do need to monitor your partial thromboplastin time. Every institution has their own therapeutic range, and so that's really what that's just a starting dose, and you're going to have to titrate that dose based on achieving the PTT that your institution has derived. Low molecular weight heparin, slide 37. Enoxaparin is the drug that's used most commonly here. It's basically unfractionated heparin that's been cleaved so that the molecular weight is smaller. The molecules are more consistent. There's less inter-individual differences in pharmacodynamics and pharmacokinetics. There's no need to monitor for anticoagulant effect, although some institutions are doing anti-factor 10A levels. It's not necessary, we don't believe. You can give the recommended dose for unstable angina without monitoring for anticoagulant efficacy. You still probably should do CBCs and look at platelet counts, hemoglobin, hematocrit, etc., but testing for the anticoagulant effect is not necessary. Low molecular weight heparin also is less likely to cause thrombocytopenia, although if you have a patient with heparin-induced thrombocytopenia, you should not expose the patient to enoxaparin. The major problem with this drug is bleeding, and reversing the effect of enoxaparin, there isn't a tried and true antidote. With heparin, we know that you can give protamine. With low molecular weight heparin, enoxaparin, protamine only partially reverses that effect. And that's because it's a factor 10 more than factor 2 inhibitor. So we're not certain, what strategy, if you have someone who's severe hemorrhage, it may require administration of blood products. The use of fresh frozen plasma to restore clotting factors may be required. Low molecular weight heparin can be given intravenously, but it means its duration of effect is going to be shorter. Giving it subcutaneously does prolong the duration of action because of the prolonged rate of absorption. So it's absorbed over a longer period of time. So when you give it sub-Q, every 12-hour works well. If you give it IV, you're probably going to have to give it every 6 hours. So really, there isn't probably much indication to give this drug IV except in the cath lab. Enoxaparin is cleared renally, and so when your creatinine clearance is below 30 to 40, then you need to make a dose adjustment. The approved dose for acute coronary syndrome is 1 milligram per kilogram sub-Q every 12 hours, or a 1.5 milligram per kilogram dose once a day. The renal dosing recommendation is 1 milligram per kilogram once a day. That's for a creatinine clearance between 10 and 30 mLs per minute. If the patient goes to the cath lab and they've been on enoxaparin for 2 doses or more, and they received enoxaparin in the last 8 hours, they don't need additional antithrombotic therapy. If it's been longer than 8 hours, then the recommendation is to give an additional 0.3 milligrams per kilogram IV before you do the angioplasty. Low molecular weight heparin does not substantially affect the ACT, so you can't really monitor the anticoagulant effect in the cath lab, and you cannot use low molecular weight heparin in patients with a history of HIT or with active HIT, heparin-induced thrombocytopenia. Direct thrombin inhibitors on slide 39, bivalirudin is indicated to be used as an alternative in the cath lab. We've talked about this. It is a synthetic derivative of hirudin, which is derived from the leeches. It's a reversible thrombin inhibition. The downside with this drug is that it is cleared renally. So as the renal function declines, the half-life increases, and you have to make dose adjustments. Again, we do use this drug for patients, 1, who are at higher risk of bleeding during PCI, or 2, if the patient has a history of heparin-induced thrombocytopenia. So the dose that's been used, the Acuity trial, the dose is on slide 39. There is a renal adjustment dose for patients with creatinine clearances less than 30. There's also a dose recommendation for patients who don't have kidney function at all that are on dialysis. So bivalirudin, I think, is a reasonable alternative to heparin and glycoprotein 2B3 receptor antagonist in patients, particularly those at higher risk for bleeding or with a history of HIT. Argatroban, also a synthetic direct thrombin inhibitor. It is reversible. Cleared predominantly through the liver, so you don't have to worry about renal dysfunction. You don't have to make dose adjustments. It's been used in PCI. It's actually a class 1B recommendation for patients with a history of HIT. We don't have a lot of experience with it, but we use it more in our patients that are in the intensive care unit who develop HIT and need anticoagulation. But the doses are listed there, and it does affect the ACT, so you can monitor the ACT with argatroban in the cath lab if you decide to use it in that setting. Fondaparinux is a synthetic pentasaccharide that is a predominant factor Xa inhibitor, predominantly developed for post-knee and hip arthroplasty prophylaxis. But there is some data in acute coronary syndrome, the OASIS 5 trial. It has a long half-life. It's cleared renally. And that's one of the things that we have some concern about, the long half-life, and if our patients develop contrast-induced nephropathy. It's tough to monitor the laboratory effect. I mean, anti-factor Xa levels may be useful. It doesn't appear to affect platelets, so no thrombocytopenia. Again, there is data suggesting that compared to enoxaparin, that the rates of bleeding were less with fondaparinux compared to enoxaparin, and that when they looked at mortality, it was no significant difference, a little bit higher with fondaparinux. But again, I think most physicians tend to want to stick with 1 or 2 products they get comfortable with, and so I just don't know that fondaparinux is caught on as an adjunct antithrombotic therapy for patients undergoing PCI. So, in terms of long-term management of folks who come in with non-ST acute coronary syndrome, one issue is if they've developed an infarct, they have the enzymes, they've got echo evidence of myocardial damage, They need to be on the same drugs that STEMI patients are on long term. Aspirin or antiplatelet drugs could be, including clopidogrel, or maybe even Prasugrel, depending whether they got stented or not. They need to be on beta blocker, they need to be on a statin, and they need to be on an ACE inhibitor. That's if they've had an infarct. Now, if they only had unstable angina, then the question is, what do they have to be on? Well, it kind of depends if they've got stented or not, if they have ongoing ischemia or not, but there aren't hard guidelines to tell us, yeah, you've got to be on a beta blocker post unstable angina. We just don't have that data. Most of the time they will be. Most of the time we treat unstable angina patients almost as if they've had non-STEMI, but the guidelines don't tell us absolutely that that's the best way to go. So on slide 42, obviously discharge education and long-term medical therapy are things that have to be discussed with these patients when they leave. Patients that do not have adequate revascularization, they either didn't have PCI or CABG, or they couldn't dilate all of the arteries that they needed to, may need to go home on anti-ischemic therapy. We kind of just talked about that. They may need beta blockers and nitrates and calcium antagonists to treat angina. All patients should go home with sublingual nitro. They should know how to use it. They should know how to call 911. They should know CPR, etc. These are patients that are at similar risk to those that have had STEMI. And so they need, I think, the similar educational approach that the STEMI patients had. Long-term therapy, again, we've kind of talked about this, but antiplatelet therapy, beta blocker, statin, ACE inhibitor, these are the same drugs that the folks with STEMI had. And again, if they technically don't meet the definition of MI, you could argue, well, they don't have to be on a beta blocker. But I think the majority probably are. So, I think you look at which patients are going to benefit the most. From long-term therapy, it's going to be the patient that's had the infarct, that has LV dysfunction, that may have diabetes, that may have heart failure. Those are the folks that will benefit the most from these long-term drugs that we typically give to patients who've suffered myocardial infarction. So that concludes the presentation on non-ST acute coronary syndrome, and I thank you for listening.